also visible impulse, and loud P2. If there is right ventricular hypertrophy, you may get lower left parasternal heave. You may also get epigastric impulse. If there is right ventricular failure, you get classical signs of engorged neck vein, pedal edema, hepatosplenomegaly, and ascites. Some patients with a massive enlargement of left atrium will present with dysphagia and hoarseness. And features of cardiac output insufficiency will be pallor, cyanosis, angina. Interestingly, the left ventricular failure will also produce exactly similar features. So these features are very common actually. The flow of the blood into left ventricle causes enlargement of the left ventricle. And the enlarged left ventricle typically would cause, in this case, a forceful apex. But as the blood rapidly goes out, it will also be ill-sustained. Interestingly, the apex will be shifted down and out because of the left ventricular hypertrophy. Raghava Lakshmi, you were asking both MS and MR present similarly, so how to differentiate from history? I'll answer this question shortly. It's a very good question. Because of the backflow of the blood, some murmur will be produced, and the murmur, as you can understand, typically happens during left ventricular systole. So you typically get a pansystolic murmur, which has a blowing quality. It sounds like flute. And this typically happens at the apex. So is this clear to everyone? Can we change this slide and now go to the case sheet to solve the case? Wonderful. So as we have seen in this flow chart, that the patient can present at various points. For simplicity, we will assume that we are taking a case of valvular mitral regurgitation, probably of rheumatic etiology, in a 19-year-old male with pulmonary hypertension and right ventricular hypertrophy without right heart failure. So essentially, I have kept the same thing as mitral stenosis case, only the MS becomes MR. Now, Raghava Lakshmi, the question that you asked me, the answer is given at the bottom of this page. You cannot differentiate between the two. The history will be same as mitral stenosis. So that is why I said this is a very good question. That is why you have to be very careful with the case of MS. MS, MR, and even MS plus MR, they have the same kind of history. It is impossible. You just saw that in the flow chart. Those findings which are different are all clinical sign, not symptom. But the symptoms are all looking similar. Patient will only tell you the symptom, not the sign. So you cannot differentiate in history whether it is MS or MR. That is, in a way, a boon in disguise that you have to read less. The same case can be presented as MR or MS, but the difference will easily come out through the murmur. So let us go into the description. So I'm not reading through the history. It's the same history. It's just copied and pasted. The same history, same negative history, everything. Let us go into the general survey. So What will be the findings in general survey in a patient with mitral regurgitation? Let us see. Patient is alert, conscious, cooperative. Faces, again, it may be normal, or there may be a cyanotic hue. This is more common because the patient has left ventricular failure. That may be present here. Decubitus, if the patient is breathless. Sneha, you are asking, electrical activity finding can only help. Of course not. We have not discussed any electrical activity finding here. Electrical activity refers to the electrocardiogram. Mechanical activity is seen by auscultation and by echocardiogram. This is differentiated by other mechanical activities. We shall see how to differentiate between the two. So decubitus, depending on whether the patient is in failure, can be either of choice or maybe propped up if the patient is breathless. Build and nutrition, whatever you get, you write. You cannot actually make it up. Pallor may be present because less blood is flowing to the skin. Cyanosis may be present because of pulmonary edema and reduced cardiac output. Yes, you can get mitral phases also. Of course, you can get mitral phases. Icterus has no significance. If it is present, it may be due to some other reason. Clubbing, if present, will indicate a long duration of disease. Edema in this particular case will be absent because we said that there is no right ventricular failure. For the same reason, neck vein will not be engorged. Do not write neck vein absent. You write not engorged. Neck gland, whatever you get, you write. Pulse, BP, respiration, temperature, again, whatever you get, you should write. So these are the general survey features. Now tell me, so could we also differentiate MS and MR through general survey? No. So this is equally difficult and funny. That means the same case can present to you as MS or MR unless you touch the patient. Once you start examining the precordium, you start getting differences. But before that, you don't get any difference. They look all the same. So everything will be same up to general survey. Let's see what the other points will be now. So precordial examination typically starts with inspection. And let us see. We are talking here about a 19-year-old boy who has developed mitral regurgitation. So do you think there will be deformity? No, there will be no deformity. Scar depends on previous operation. Venous prominence totally depends. No venous prominence will be present due to right heart failure here, but other minor causes may be present. Coming to visible pulsation. Now you tell me, all of you write down what are the pulsation you are expecting here. I'm not going through all the points. Just tell me in this particular case with a patient of MR with pulmonary hypertension and right ventricular hypertrophy, what are the pulsations you are expecting? Anyone? Very good. So you may get epigastric, lower left parasternal for right ventricular hypertrophy, mitral for the heaving apex or the hyperdynamic apex. For pulmonary area, you can get one impulse for pulmonary hypertension. So essentially, the extra thing over mitral stenosis that you get on inspection is the apical impulse. Apical impulse is not present in mitral stenosis because the left ventricle is not enlarged. That is one extra thing, the mitral area impulse or apical impulse, which is extra. All others are same as that of mitral stenosis. So you see, the moment you start examining the precordium, differences are coming. So you start getting the differences. So epigastric and lower left parasternal for right ventricular hypertrophy, mitral for left ventricular hypertrophy, pulmonary may be possible if there is pulmonary hypertension. These are the impulses that may be visible. Whatever is visible is also palpable. So if you look into the findings, what will be the site and character of the apex? Raghavalakshmi, why do you think there will be a suprasternal impulse? What is the cause of suprasternal impulse? The cause of suprasternal impulse is aneurysm of arch of aorta. That is definitely not present here. Yes, very good. Apex will be down and out, and the character will be forceful and, is it well sustained or ill sustained? Forceful, ill sustained. That is synonymously called hyperdynamic. Forceful and ill sustained is also known as hyperdynamic. So you will typically get a down and out apex which is forceful and ill sustained. Thrill, as I have always told you, you check the thrill along with the murmur. If a thrill is present, suppose there is a thrill, will it be a systolic thrill or a diastolic thrill? Very good, systolic thrill. If you have ever have any confusion, if the apex beat will be ill sustained or well sustained, you ask yourself a simple question. Does it take longer time for the left ventricle to empty, or does it take shorter time to empty? The duration of emptying is the duration of the apex. So basically, if two sides are open, mitral and aortic, blood will easily come out of the ventricle, so it empties rapidly, so it is ill sustained. And if there is outflow tract obstruction, it will be well sustained. So now think in a reverse manner. The mitral valve do not close, so they don't clap. If the mitral valves don't touch each other, would you get a loud S1? You'll get a soft S1. So if the S1 is soft, can it be palpable? No. So palpable S1 is absent. Would you expect a palpable P2 in this patient? Yes, we will be expecting a palpable P2 if there is pulmonary hypertension. Very good. Will you expect lower left parasternal heave? Yes, that is because of right ventricular hypertrophy. Will you expect any finding in the aortic area? No, because it is not related with aortic pathology. Wonderful. So palpation is over. We move on to the auscultatory findings following the same format. So heart rate, whatever you get, you write. So many beats per minute. Read them, be very careful. If in pulse you write irregular, then in the heart also you write irregular. And assuming it is atrial fibrillation, other findings should be like atrial fibrillation. If in the pulse you write regular, then in the heart rate also you write regular, and then all other findings should be without atrial fibrillation. I am assuming this to be regular here. So now comment on the heart sound. S1, what will be the finding of the heart sound? S1 is normal, loud or muffled. Muffled means soft. Very good, muffled. So at this point, can I ask you one question? I thought someone will ask me this question. Since you are not asking, I'm asking you the same question. If the mitral valves are not touching each other, why at all will there be a sound? Why am I not saying that S1 is absent? Why am I saying it is muffled? Anyone who wants to answer can answer. You can also unmute yourself and answer if you want to speak to me. So my question is, if the mitral valve leaflets are not touching each other, they cannot close, why will the sound at all be present?
Sir, sound is not due to the closing, it's actually due to the turbulence caused by the blood.
Very good.
It's
So we know
due to
that, very
vibration.
good, Alam. So the reason is all heart sounds have three components. Yes, very good, Monisha, due to the other components. There are valvular component, vascular component, and muscular component. So when a valve closes, the closure of the valve produces sound, the turbulence in the blood vessel produces sound, and the vibration of the wall of the chamber of the heart also produces the sound. These three sounds together combine to form the heart sound. So although here the valvular component is absent, the vascular and muscular components are present. That is causing a muffling of the sound. Very good, all of you. So this is the reason you don't get absent S1, you get a muffled S1. What about S2? What will happen to A2 and P2? Will A2 be normal, loud, or muffled? Splitting is a different point. I'll discuss it under splitting. Will A2 be loud or normal or muffled? P2 will be loud, but A2 will be normal. There is no aortic pathology. So A2 will be normal. See, in the whole flow chart, we have commented nothing about A2. P2 will be loud because of pulmonary arterial hypertension. As long as you don't get any heart failure, left heart failure, you don't comment on S3, S4. And for exam purpose, I'm telling you, it is best not to comment on that because it's very difficult to demonstrate S3 and S4. You simply say not heard. Splitting here will be normal. Normal means A2 followed by P2. That is the rule, and here also there will be A2 followed by P2. You can argue that A2 will happen earlier, causing a wide split, which is okay. A wide splitting is still a normal splitting because A2 is followed by P2. So it is slightly wider. Of course, it's wide, but you may not mention that. So you can just say it's normal. Only when it is reversed or absent, we comment on that. You're saying that how do we find out whether we are hearing S3? To be very honest with you, the best way to find out these heart sounds, S3 and S4, is by phonocardiography. It's very difficult to do it in the bedside. Nowadays, we have stethoscopes with inbuilt phonocardiograph. So we can actually plot them graphically and understand. Clinically speaking, if you want to find out whether we are hearing S3 or we are hearing S2, there is one difference that you can use that we sometimes say that when talking about S3, for example, when you are, say, the patient is in a lying position and you lift the leg of the patient, more venous return goes to the right side of the heart and therefore again circuitrically to the left side of the heart. Turbulence of blood from atrium to ventricle produces S3. So S3 will technically accentuate. So if you hear a sound following the S2 and you think this is a third component of the sound which increases on lifting the leg end of the patient, then probably you're hearing the S3. That is one way to find out. But the best way is to do a phonocardiography. Then comes opening snap. So will you get any opening snap in mitral regurgitation? No. Ejection click, I already told you, this is related to aortic pathology. So it does not apply in this case. Let us now talk about the classical murmur of mitral regurgitation. What is the site of the murmur? The site is apex, or you can also say mitral area. Timing of the murmur is pansystolic. Position of the patient. For mitral valve pathology, the best position is same. That is either stooped forward or left lateral. Now let me describe the murmur. The pitch of the murmur is high. It's a shrill murmur. The quality is described as blowing murmur. It's like a flute. depending on whether you have thrill, the grade can be either 3 or 4. So now that we know that the pitch is high, so will it be heard better with a bell or with a diaphragm? Yes, so it is heard better with a diaphragm. You know that mitral valve is on the left side of the heart. So is it heard better in inspiration or expiration? Very good, expiration. Mitral valve has two leaflets. So if I draw the two leaflets of the mitral valve, suppose this is the orifice or annulus of the mitral valve, and the two leaflets of the mitral valve hang like this. There is one leaflet behind and one leaflet in front. So they are actually not behind and in front. Instead, a more accurate way to say will be the anterior one is more anterolaterally, that is, it faces the axilla, and the posterior one faces the interscapular region. That is why if the damage to the valve occurs mainly in the anterior mitral leaflet, so if the anterior mitral leaflet is mainly damaged, the sound has a tendency, the murmur has a tendency to be conducted towards the axilla. If the posterior mitral leaflet is selectively damaged, then the tendency of the murmur is to flow towards the back of the patient, that is interscapular region. If both are damaged, it will flow both ways. Now, it is a statistical finding that most commonly the anterior mitral leaflet is damaged. So conduction occurs usually to axilla, occasionally to interscapular region. Because there is no question of pericarditis in this patient, so pericardial rub is absent. So is this clear to everyone? The auscultatory findings of mitral stenosis and mitral regurgitation. This same conduction is not seen in MS because in MS, the valve leaflets are calcified, so they move. As they don't move, there is no vibration. If there is no vibration, there will be no sound produced along a direction. The only sound that is produced in MS is due to flow of blood. And the blood flows from the atrium towards the apex. So the sound flows towards the apex and not anywhere else. So I hope this is clear with everyone. So if you see the chest X-ray in a patient with mitral stenosis, you saw there was straightening of the left border. What is the finding that, a very prominent finding that you are seeing in this X-ray? This is from mitral regurgitation. What is the prominent finding that you are seeing? You don't comment on the apex in an X-ray. It is a 2D picture, so we do not know what is the apex here. Yes, the cardiothoracic ratio. So if this is the midline, I think this is the maximum diameter on this side, and this is the probable maximum diameter on this side. So if you add these two and take the internal diameter of the chest, internal means from inside the rib to inside. I think this is where it is widest. So simply plot them. It is quite obvious that it is more than half. It's just visibly more than half. So the cardiothoracic ratio is more than 0.5 and therefore there is cardiomegaly. That is expected. If there is left ventricular dilation, there will be cardiomegaly. So the most prominent finding will be cardiomegaly on the chest X-ray. Is this clear? If you do an echocardiography, you will be able to see the regurgitant fraction. Now, again, I told you echocardiography cannot be learned like this. This is only for your interest. I'm showing you a GIF image so that you understand how it looks like. So you can see the colored flow of blood that is happening from below to upward. The blood that is flowing from below to upward in this picture, that is the regurgitant blood, the oppositely flowing blood. So this is how it might look like. Common questions that you are asked from here are, why are you saying this is mitral regurgitation? Can someone answer? You can unmute and answer also. You already know how to answer. So why are you saying this is a case of mitral regurgitation? You will start with inspection, then palpation, then auscultation, and then summarize your answer. Is there someone who wants to answer? Why are you saying mitral regurgitation? This is mitral regurgitation because, yes, on inspection, there is an impulse over the mitral area. Very good. Then on palpation, the apex is forceful, ill-sustained, and down and out. And on on auscultation, there is a pan-systolic blowing murmur at the apex radiating towards the axilla or back. All these points favor your diagnosis that this is a mitral regurgitation. Why are you saying that the mitral regurgitation is valvular in nature? Anyone? Why are you saying that the mitral regurgitation is valvular? Because of the soft S1. Very good. Because of the soft S1. Opening snap absent is not a point because opening snap should not be present. Nothing opens here. S1 is muffled because S1 has a valvular component. If the valves were not affected, then S1 should not be significantly affected. Very good. Why do you say it is rheumatic mitral regurgitation? The same kind of answer. Either you say the patient has told me that there was rheumatic fever and penicillin prophylaxis, or you say this is the commonest cause unless otherwise proven. Why do you say there is left ventricular hypertrophy? Who will answer this? What are the features of left ventricular hypertrophy in this patient? No, you cannot use the word cardiomegaly in the bedside.
Forceful apex shifted downward.
Very good. Forceful apex shifted down and out.
Out and down.
That is the feature of left ventricular hypertrophy. Very good. Why do you say there is pulmonary arterial hypertension?
Palpable P2 and loud P2.
Very good. Palpable P2 and loud P2. Why do you say there is right ventricular hypertrophy?
Left lower parasternal heave and epigastric impulse.
Very good. And also the apex may be outwards. But in this case, there is a combination of the two. So you should not comment on that. So we come back to the other questions, complications of MR. So other than atrial fibrillation and thromboembolism, all valvular heart diseases have similar complication, increased risk of infective endocarditis, increased risk of another attack of rheumatic fever. One question that can be asked is, the risk of infective endocarditis is more common in mitral regurgitation than in mitral stenosis. Why? Can someone answer? Why infective endocarditis is more common in MR than MS? I'm giving you a hint. compared to MR and MS, in which case blood flow is more turbulent or more rapid? Obviously in MR. And the criteria, the first criteria for infective endocarditis is injury to the endocardium. And the injury occurs due to rapid blood flow. Because blood flow is more rapid in mitral regurgitation, chance of endocarditis is more common in mitral regurgitation. It's a simple answer. So with this class, the first part is over. Let us check our understanding and see whether we have been able to understand how mitral valve pathologies will present to us. Try this one. What is the commonest cause of mitral stenosis?
Rheumatic.
Very good. The murmur of mitral stenosis is?
Mid and late diastole.
Yes, it is mid and late diastolic. MS or mitral stenosis can dilate all chambers except
Pyrethrum.
we have seen the
Right
pathophysiology. The answer is B, left ventricle, because left ventricle receives less blood and it cannot dilate. All other chambers are congested and therefore they can dilate. If a patient with mitral stenosis has no presystolic accentuation, what does it mean? Very good. It means that there is atrial fibrillation. Now, this I did not explain, but I want you to think and tell me. If the gap between the A2 second heart sound and opening snap is less, does it indicate a more severe disease or less severe disease? The answer is B, more severe. I'll explain this answer a little bit for those who did not get it. Suppose this is the time scale of cardiac cycle, and this is the first heart sound. This is the second heart sound having A2 and P2 components. This is the next first heart sound. Diastole is longer, so I'm drawing the diastole longer. So of course, this is systole, this is diastole. This is S1. These are A2 and P2. That is S2. And this is the next S1. Now the murmur of mitral stenosis is mid-diastolic and a rumbling murmur. So the murmur typically starts with an opening snap. So a point comes when the valve snaps open and then starts the murmur. Then the murmur starts as a rumbling sound and it keeps on continuing towards the end of the diastole. So this is how the murmur typically looks like. Now the gap that we are talking about here, the gap in question is this gap. Because the dark blue line is the opening snap. And these red lines indicate the mid-diastolic murmur. This is also known as a graphical representation of auscultatory findings in mitral stenosis. So why is this gap so important? Think of the cardiac cycle. When the ventricle undergoes diastole, it gradually relaxes. The pressure in the ventricle falls. When it is just below the atrial pressure, the mitral valve opens. So opening snap represents that time when the mitral valve just opens. That is the time when the ventricular pressure is just less than the atrial pressure. Now understand, if the atrial pressure is much high, then the opening occurs faster. That's a common sense. If you have more pressure above, you will open the door much more easily. And if the atrial pressure is less, the opening snap will happen late. It will take longer time to open the door. What does high pressure mean? More blood is accumulating. What does more blood accumulating mean? Less blood is flowing. That means there is a more tight stenosis. So in a flow chart, if we write this, if there is a more severe MS, there will be greater atrial congestion. This means there will be greater atrial pressure. This means there will be rapid opening of mitral valve. And therefore the time taken for opening will be less. So there will be a shorter A2OS gap. That is why we often ask this question, why is the A2OS gap inversely proportional to the mitral valve functioning? Because the shorter the value of A2OS gap, more severe is the disease. This is the explanation. Is this clear? Okay. Try the next question. The question will load in a while. Persistent pulmonary edema can cause. Which one? Very good. Pulmonary arterial hypertension. Commonest cause of chronic mitral regurgitation.
Rheumatic.
Very good. All cause of chronic valvular disease is rheumatic, commonest cause. Murmur of mitral regurgitation is
Pansystolic.
very good, pansystolic. Where does the murmur of MR radiate? Radiate means conduction.
Both.
Yes, depending on which leaflet is affected, it can be both axilla or interscapular. And the last question, in mitral regurgitation, the first heart sound is
Muffled.
very good, it is muffled. So that was the discussion on mitral valve pathologies. So you can ask me if you have any question. And Pranava, Vishnu, maybe we can end the session one here. You can keep logged in, just mute yourself. And Pranava, you let me know how many minutes later we can join. Then accordingly, I'll just come and log in.
Yes, sir. So, according to you, how much time should we break out for?
I think the students are a little bit exhausted. So can we give them about, say, 10 minutes of time?
Yes, sir. So 3:20.
Yeah, I think that will be great. This is five. Yeah, this is 3:09. So at 3:20, we sharp start the session.
Okay, sir.
Okay. Thank you so much.
So see you all at 3:20. Good afternoon, sir. Should we begin?
Good afternoon. So, yeah, we can begin.
Okay. Good afternoon, everyone. The next session will be on diseases of the aortic valve. So, sir, over to you.
Thank you. Let's start. So, we have discussed about the pathology of different diseases of the mitral valve. Uh, this has already created a background of how to examine the cardiovascular system. Let us now start with diseases of the aortic valve. As usual, we'll start with a few questions for ice breaking and then get into the discussion. So let us try these questions. Angina can occur in which of these diseases do you think angina can happen or chest pain can happen? Okay, next question. Forceful and ill-sustained apex is seen in. You can choose more than one option. I mean, just because I told you to choose more than one option doesn't mean that you have to choose more than one option. Only one option can also be correct. Okay, we'll pass over to the next question. Collapsing pulse is seen in. Okay, we'll move on to the next question. Murmur of aortic stenosis is. What is the timing of the murmur of aortic stenosis? Next, paradoxical splitting of the second heart sound may be seen in. Okay, the next question. Austin Flint murmur is not. So which is incorrect about Austin Flint murmur? Okay. So let us start with the diseases of the aortic valve and we'll come back to these questions. The first disease of aortic valve that we are going to study is aortic stenosis. And as the name suggests, stenosis means narrowing. So aortic stenosis means essentially narrowing of the aortic valve. Now, if you see the architecture of the outflow canal of the left ventricle, it will look something like this. So if this is the heart, and if this is the aorta, then a part of this aorta merges with the ventricular muscle and septum. In between lies the opening or the orifice or the annulus of the aortic valve. So if this is the orifice of the aortic valve, it lies somewhere here. So when we talk of obstruction in flow of blood through this channel, the obstruction can be at various levels. The obstruction can happen somewhere below here at the orifice may become narrow, or above the orifice, making a constriction of the aorta. Accordingly, the obstruction of the orifice is known as valvular stenosis. Obstruction below the orifice is called subvalvular stenosis, and obstruction above the orifice is called supravalvular stenosis. But in effect, they produce the same thing. They cause obstruction to outflow of blood from left ventricle. So technically they are all aortic stenosis, but truly valvular stenosis is the stenosis that occurs around the orifice. Subvalvular and supravalvular are either disorders of the muscle or disorders of the blood vessel, but they clinically produce the same effect, that is narrowing of the outflow of left ventricle. So this is the rationale of classifying aortic stenosis anatomically into valvular, subvalvular, and supravalvular. Valvular aortic stenosis may be acquired and congenital, and as usual, for valvular stenosis, the commonest acquired cause is rheumatic. Other less common causes are fibrocalcific deformity, autoimmune diseases, infective endocarditis, deposition diseases like Fabry's disease, or it can be a congenital deformity. Subvalvular deformity occurs in an embryological deformity called tunnel deformity, also in hypertrophic cardiomyopathy, where the muscle becomes very thick and it compresses at the lower part of the channel, outflow channel. Supravalvular stenosis occurs if there is constriction of the aorta or a congenital hypoplasia of the aorta. So these are the common causes of aortic stenosis. Today we will talk about a specific case of aortic stenosis that has particular features. But before we get into that, let us first understand the pathophysiology and hemodynamics in a patient with aortic stenosis. Let me get a blank page for this. Just a minute. So let us discuss the hemodynamics of aortic stenosis, from which we can calculate the clinical features and the clinical signs of aortic stenosis. As usual, we will always start with the most fundamental definition of the problem. Aortic stenosis means narrowing of the aortic valve. So we start with narrowing of aortic valve. If the aortic valve becomes narrow, the problem that we face is that there is reduced flow of blood from left ventricle to aorta. This reduced flow of blood from left ventricle to aorta will immediately cause two problems. On one hand, we will see that there is reduced left ventricular cardiac output to aorta. On the other hand, we will see there is pressure and volume overload, mainly pressure because it's outflow obstruction, but also the blood volume is accumulating, so volume overload also occurs. Pressure and volume overload to left ventricle. Whenever there is a overloading of any ventricle, it responds by hypertrophy. So there is left ventricular hypertrophy. The left ventricular hypertrophy, if uncontrolled, will lead to left ventricular failure. The reduced left ventricular cardiac output to the aorta typically will produce features of ischemia that will include syncope. Due to reduced coronary flow, there will be angina. Due to reduced flow to muscles, there will be fatigue. Due to reduced flow to the kidneys, there may be oliguria. In the skin, there may be pallor, and in severe cases, cyanosis. Interestingly, these are also same as the forward features of the left ventricular failure. So these features are produced both ways, by direct reduction of blood flow, and also in the late stage, it is aggravated by left ventricular failure. If the left ventricular failure becomes an important phenomenon, that is, if it dominates, then it will have its own forward features as well as the backward features. And the backward features will include left atrial congestion, this can lead to a left atrial dilation, which can lead to pulmonary venous congestion, which will lead to raised pulmonary capillary wedge pressure, that leads to pulmonary edema. This is where the disease process will stay for a number of years. But if it is not treated, then the pulmonary edema leads to pulmonary arterial hypertension. That will lead to right ventricular hypertrophy. And if it is not treated, this will lead to right ventricular failure. So this is a pretty simple pathophysiology, as you can see, and this is what happens when the aortic valve becomes narrow. We will now try to find out the clinical signs symptoms that can generate because of this pathophysiology. Is this pathophysiology clear to everyone? Okay, so let us now see what are the consequences of these changes. If there is left ventricular hypertrophy, this will lead to a forceful and well-sustained epics. It is well-sustained because it takes a longer time for the ventricle to empty. We have already listed the possible signs and symptoms of left ventricular failure as forward features. But if left ventricular failure continues, this will also lead to backward features, and the backward feature is pulmonary edema. So the patient might come with pink frothy sputum, and on auscultation you may get bilateral basal crepitations. If the patient has pulmonary arterial hypertension, if it progresses to that stage, then you will always get a palpable and loud P2. If it progresses to the level of right ventricular hypertrophy, then definitely you will be getting features like lowered left parasternal heave and in severe cases epigastric pulsation. If the patient presents with features of right ventricular failure, you get the classical features like engorged neck vein, pedal edema, hepatosplenomegaly, and in severe cases ascites. Because of the reduced left ventricular cardiac output, the pulse becomes feeble, so there will be low volume pulse, and also the pulse wave rises slowly because blood comes out slowly. This low volume, slowly rising pulse is sometimes called pulsus tardus. If the patient presents with left ventricular hypertrophy, not only will there be a forceful, well-sustained apex, apex will also be shifted down and out. And in severe left ventricular failure, you may get a third heart sound. Now, because of the narrowing of the aortic valve, there is not only reduced blood flow, there is turbulent blood flow from left ventricle to aorta. So as blood flows through the abnormal valve, a murmur is produced. The murmur starts as blood is ejected in the systole, and therefore it is called ejection systolic murmur. Basically, it is a systolic murmur. If the valve is partly calcified, then similar to opening snap, here also you will get a sound. The sound of atrioventricular valve is different from the semilunar valve. The semilunar valves produce a clicking sound and not a snapping sound. So this is also called ejection click. As the aortic valve is calcified, so the A2 becomes of diminished intensity. This is very peculiar. In mitral stenosis, we found that the mitral valve, when it was partly calcified, the sound became loud. But in aortic valve pathology, the problem is that the semilunar valves, if less blood is going to the aorta, then the pressure in the aorta is less. When valves close against high pressure, sound becomes high. When valves close against low pressure, sound becomes low. In mitral stenosis, valve was closing against the atrium. As it was closing against the atrium, which has high pressure, the sound was loud. Here, the valve is closing against the aorta, and this aorta has low pressure. Therefore, the A2 becomes soft. So you get a soft or muffled A2. It also takes a longer time for the left ventricle to empty. So A2 appears much later. So considering this, see, suppose this is the timing of the cardiac cycle, and this is the A2 component, this is the P2 component, and normally A2 happens before P2. Now, because the time taken for left ventricle to close is more, so A2 occurs much later. A2 happens at a later time. As a result of this, the A2 comes closer to P2. P2 has no problem. So the split becomes narrow. If the A2 closes so late that it is even later than the P2. So if this much of time was taken for left ventricle to close, then A2 might appear after P2. And this is called paradoxical splitting. I'll explain how that can be investigated. So my point is, the left ventricle is taking longer time to shut down. So aortic sound is coming much later. If it occurs slightly later, it will come close to P2. There will be narrow split. Technically, there will be a time when they will be just on each other. Then there will be no split. And if it takes even longer, it will cross P2 and move to the right side, and then there will be reversal of the split or paradoxical split. So A2 will be soft, and the split can be anything between narrow or absent or reversed, depending on the severity. Is this clear? So keeping these findings in mind, we can now solve the case with certain criteria. So I am moving away from this slide. Let us go to the clinical page to solve the problem. Muskan, what is the question that you are facing? You can write down the question. Or you can ask the question directly. Yes, I'll explain the A2P2 part once again. In normal situation, left ventricle empties faster than right ventricle because the flow in left ventricle is more rapid than right ventricle. As the left ventricle closes, the aortic valves close and you get one sound. That is A2. As the right ventricle closes, the pulmonary valves close and you get the second sound, P2. So normally A2 happens first and P2 happens next. Now, the left ventricle outflow tract has become narrow. As it is narrow, it's taking a longer time for the blood to go out. Only after the blood goes out, the valve will close after the pressure gradient opposes. So as it is taking a longer time, so A2 happens later than predicted. So if it happens slightly late, then you can see from the graph, the position comes closer to the position of the P2. If it occurs even later, it overlaps with P2. And if it occurs still later, it crosses P2. If it occurs slightly before P2, the split becomes narrow. If it occurs on P2, there will be no split. And if it goes beyond P2, there will be reversal of the split. That is, P2 happens before A2. Is it clear now? Okay, fine. So we'll move on from this slide and let us go to the clinical case. So as usual, we will choose a case with certain criteria and try to solve it accordingly. So this is one common kind of case that you will get in the clinical world. A case of valvular aortic stenosis, probably of rheumatic etiology, in a 22-year-old male with left ventricular hypertrophy, but no left ventricular failure at present. Nothing is said about the right ventricle. So the disease is up to left ventricular hypertrophy, but Left ventricular failure has not happened. So this is the case, a very simple case. Let us try to solve this one. You see, as I told you, patients' main complaints are due to less blood flow. So blackout or syncope and chest pain or angina are very common problems. So the chief complaint can be intermittent chest pain and occasional blackout. You always start with the history of present illness from the time when the patient was apparently healthy. So you say that the patient was apparently symptom-free 2 years back. Both of the symptoms, you can either say appeared simultaneously or based on the chief complaint, they happened one after the other, whatever the case is. The onset was gradual, the symptoms were progressive. He visited the hospital for the above symptoms, mention the dates. There has been no appreciable change in his condition after hospitalization. Now, as I told you, you should always give evidence towards your diagnosis. You are suspecting this angina to be cardiac in nature, but people can say it is a pleuritic pain. People can say it's a pain originating in the bronchus. It's a pain originating in the mediastinum. How do you differentiate? So you give history specific for chest pain of cardiac origin. It is precipitated by exertion, relieved promptly by rest. Like NYHA scale of breathlessness, there is also an NYHA or CCS scale of angina. It's the same criteria. So you grade the pain. You ask that person, do you have pain while lying in bed? Do you have pain after walking 10 steps? Do you have pain after climbing a flight of stairs? Do you have pain after climbing 3 flights of stairs? Accordingly, it can be 4, 3, 2, 1. So you grade the severity of the pain and mention if there is a nocturnal awakening, because this can happen in angina which is unstable in nature. If it is an exercise induced angina, there will be no nocturnal awakening. The blackout or syncope has the following features: precipitated by standing up and relieved by lying down. What does it indicate? It indicates it depends on gravity. That means it depends on circulatory system. So this and syncope is probably not a conversion reaction of psychiatry. It is probably not an absence seizure or atonic seizure. So neurological syncope can happen anytime. It has no relation with standing up and lying down. You are mentioning this is a circulatory syncope that we are dealing with. Again, emphasizing that this is a cardiovascular system disease. Take negative history which is relevant to the case. There is no history of prolonged cough. You are ruling out other diseases like tuberculosis that can cause chest pain, blood spitting, pink-frothy sputum, ruling out pulmonary edema. So there is no left ventricular failure right now. There is no history of pedal swelling. That means you are ruling out right ventricular failure. So patient is not in failure. Known blood disease or history of blood transfusion. So there is no severe anemia which is causing the angina or the syncope. Known renal disease, hypertension, diabetes, dyslipidemia. The risk factors, the typical risk factors of hypertension or other vascular diseases. No history of convulsion. Again, you are emphasizing that these are not probably episodes of absence seizure or atonic seizure. There is no history of low mood, anxiety, psychological stress, or tendency of self-harm. You are ruling out hysterical conversion reaction or panic attacks. That can also cause syncope-like situation, chest pain-like situation. Then you say there is no history of recent prolonged fever, joint pain, hospitalization. Or if there is, you mention there is such. Currently, his symptoms persist. Sleep is slightly disturbed, bladder and bowel functions are regular, appetite is slightly reduced. Then you move on to the history of past illness. If you get a proper history of rheumatic fever, mention that. If you don't get a history of rheumatic fever, there is no need to mention the other histories. Then family history. In family history, you mention that there is no history of similar illness, because if it is rheumatic in nature, rheumatic fever doesn't run in families. Personal history, you mention about the education, the income, the relationships of the person. In menstrual history in female, don't forget to mention in detail about the menstrual history because that can explain any underlying anemia. Treatment history you take as necessary. Ask about penicillin prophylaxis and take history of allergy. And now you go into precordial examination. So remember the case, we are dealing with a case of valvular aortic stenosis with left ventricular hypertrophy but no left ventricular failure. So let us guess what will be the findings in general survey. Patient is alert, conscious and cooperative. If the patient has no failure right now, what kind of phases will you expect? Phases will be unremarkable or normal unless there is some other disease in that person. If the patient is not right now in failure, what will be the decubitus? There is nothing called normal decubitus. That is called off choice. Means patient can choose the decubitus. You will say decubitus is off choice. Build a nutrition, you have no point guessing this. Whatever you get, you mention. So is there any chance of getting pallor in this patient? Think of the pathophysiology chart and tell me. Yes, may be present. Even if there is no heart failure, the very reduction in the cardiac output can cause pallor, similar to what happened in mitral stenosis. Can there be cyanosis? Technically, yes, but it has to be very severe then. Only then peripheral cyanosis will happen. Otherwise, cyanosis can very easily happen if there is left ventricular failure. Icterus is totally unrelated, so if it is present, think of additional etiologies. Clubbing might indicate a long-standing disease. Will you get edema in general survey in this patient? Edema will be absent because there is no right ventricular failure also. By the way, hepatomegaly does not cause jaundice. Increase in size does not mean a dysfunction. If a person grows taller or fatter, does it mean all the organs become abnormal? It's not like that. The increase in size is a physiological adaptation. Next is neck vein. So will the neck vein be engorged? No, there is no failure, so it will be not engorged. Neck glands, whatever you get, you write. Pulse, you mention all the points. If it is present, then mention that the pulse has low volume. It's low volume simply because less blood is going out into the aorta. But if you get high volume pulse, mention that because it may be a case of AR plus AS. That is also possible. So pulse will be typically low volume. BP, whatever you get, you write. There is no prediction in BP here. Technically, although the systolic pressure will be low, but you never know if the person is already hypertensive. Then talking about respiration and temperature, whatever you get, you write. These are very basic vital signs. So general survey basically tells you these and gives you an idea that probably you are dealing with a compensated disease without much complication. Of course, some of these findings will change if the patient was in left ventricular failure. You could have got cyanosis very prominently and the systolic BP will be very low, pulse rate will be very high. In case it was associated with right ventricular failure, you could have got edema and engorged neck vein. So all these are findings that will keep adding if other complications are present. So I hope up to this is clear. General survey of aortic stenosis. We move on to the precordial examination in a patient with aortic stenosis. So we'll use the same format and see what can be the expected finding in this particular patient. So will you find a deformity in this 22-year-old person with aortic stenosis? Everyone? No. Had it been a pediatric disease, there could have been a deformity because there is left ventricular hypertrophy. But in an adult, you do not get deformity. Scar and venous prominence are coincidental findings. So if you get it, you interpret it accordingly. Now look at the list of visible pulsation in this particular patient who has left ventricular hypertrophy but no left ventricular failure. If there is no left ventricular failure, there is no question of right ventricular hypertrophy because pulmonary hypertension did not develop. So you tell me what are the expected areas of pulsation in this patient. As there is a left ventricular hypertrophy, you will get apical or mitral area impulse. But since there is no failure and therefore no pulmonary hypertension, so there will be no impulse in pulmonary area. As there is no pulmonary hypertension, there is no right ventricular hypertrophy, so you will not get epigastric and lower left parasternal impulse. So mitral impulse is the only impulse that is possibly present in this patient. Talking about the palpatory findings, what will be the position and character of the apex beat? So apex will be down and out, and what will be the character? Forceful and well sustained. Very good. So there will be forceful and well sustained apex shifted down and out. Very good. Thrill, as I always tell you, check it along with the murmur and accordingly grade your murmur. So will there be any palpable heart sound in this case? Is any sound going to be that loud that you can palpate? Any first or second heart sound that is palpable? Look at the flow chart of the pathogenesis up to left ventricular failure. Ideally, no. Any palpable impulse? The only palpable impulse is apex beat. Other than that, no. S3 is never a loud sound. It is always a soft sound. And even experienced clinicians miss S3, and that is never palpable. This is palpation, so the question of hearing doesn't come here. Let us go to the auscultatory findings, and we use the same format as before. So you write down the heart rate as you get it. Make sure it's same as the pulse rate. Rhythm, make sure it's same as the pulse rhythm. Now coming over to the heart sounds. What do you think will happen to the first heart sound? Will it be normal, muffled, or accentuated? Very good. It will be normal because there is nothing wrong with the mitral valve and tricuspid valve. Between A2 and P2, first comment on A2. Will the A2 be normal, muffled, or loud? A2 will be soft or muffled. Very good. Now, in this patient, there is no pulmonary hypertension. So P2 is likely to be normal. But if the patient develops pulmonary hypertension, P2 can be loud. S3 and S4, the safest thing is to say that could not be heard. Never mention that you heard S3, S4. It's a very experienced finding. We often miss this. So now comment on the splitting. We already said, what are the possibilities that you can get in the splitting? Yeah, yes. So in the actual examination, in theory, you can write like this. In practical, you don't write all the three. You say whatever you find. It is either narrow or absent or reversed. Now comes the question. When second heart sound is heard, it's like two knocks that are happening simultaneously. So it's like if the first heart sound is called lub and the second one is called dup, the splitting here sounds like this. Lub tutup, lub tutup, lub tutup. This tutup is actually the splitting. It's not widely split. This is the maximum split you can hear. My question is, when you hear this tutup, tutup, this kind of a galloping kind of sound, two sounds coming together, how do you know which one is A2 and which one is P2? I told you that you can take a deep inspiration. The sound that comes first is A2, the sound that comes next is P2. That I already told you. But now you see that there is something called reversed split. That means technically, sometime P2 can also happen before A2. Then my previous technique doesn't work. Because if something comes before, it is not necessary that it has to be A2. Sometime it can be P2 also. Now comes the actual question that you were asking that time. So how do you actually identify A2 and P2? How do you know that the split has been reversed? It will still sound like a split. Yes, with inspiration, what do you get? That is my question. With inspiration, the sounds become more separated, but then how do you know which one is A2 and which one is P2 if it is already reversed? So let me give you the answer. The answer is very interesting. Listen carefully. Suppose this is the timeline of cardiac cycle. This represents A2, the aortic component, and this is the P2. I'm sorry. Wait for a few seconds, the images will reappear. Yeah, so this is the pulmonary component. Then obviously the gap between the two is called split. I have not drawn the first heart sound here. I'm only drawing the second heart sound. So normally A2 comes first and P2 comes next. Now try to understand. When the left ventricle closes, it produces the sound A2. When the right ventricle closes, it produces the sound P2. Normally left ventricle closes earlier than right ventricle because the blood flow in left ventricle is faster, the blood flow in right ventricle is slower. What happens when you take a deep inspiration? When you take a deep inspiration, more blood comes to the right ventricle due to the negative suction pressure over superior and inferior vena cava. So P2 already takes longer time to happen. Right ventricle closes later. Now there is more blood, so it will take even longer time. So P2 shifts laterally, I mean on the right side. Again, when you take inspiration, blood accumulates in the chest cavity, so less blood goes to the left ventricle. The left ventricle, as it is, closes earlier. Now there is even less blood, so it closes even earlier, so A2 moves towards the left. So the effective distance between A2 and P2 increases. That is why we say during inspiration, the split becomes wider. Now, this basic logic is that inspiration causes right shifting of P2 and left shifting of A2. And the reason I have already told you why this happens. Now imagine, let us imagine that we are dealing with a case of reversal of split. Let us just imagine that the split is reversed. So, and we do not know that. So in this particular case, the first one is P2, second one is A2. So by the normal technique, you ask the patient, take a deep inspiration and hold. When the patient takes a deep inspiration, the basic biological logic will operate. A2 tends to move towards the left and P2 tends to move towards the right. That is the normal logic. So instead of the split becoming more prominent, the split becomes narrower or even disappears. So when on deep inspiration, the split becomes less prominent or disappears, you understand that the split is reversed. And in that case, the first sound therefore should be P2 and the second sound should be A2. And if on inspiration the split increases, which is normal, then the first sound is A2 and the second sound is P2. Is it clear to everyone? So this is how paradoxical split can be identified, and also individually A2 and P2 can be identified by clinical examination. So this part is clear, I hope. We'll move on to the next part. Opening snap. I told you opening snap does not apply to aortic valve. It applies to mitral and tricuspid valve. So opening snap will be absent. But ejection click applies to aortic valve. That is the counterpart of opening snap. So ejection click may be present if it is a rheumatic valvular disease. Now let us talk about the murmur. So obviously the murmur will be best heard over the aortic area. Timing of the murmur is ejection systolic, that is, it starts with the beginning of the systole. For all auscultation of the base of the heart, by the word base of the heart, we do not mean the bottom part, we mean the upper part. This is very interesting nomenclature. Here the word base actually means the root of the great vessels. So base of the heart is aortic and pulmonary area. Whenever you auscultate the base of the heart, the patient should be sitting upward and stooping forward. Of course, the patient can be supine also, but this is the best position in which the sound is heard. Now let us discuss about the other factors. If I give the other attributes of this murmur, let me erase this diagram first. So the murmur of aortic stenosis, the sound that is produced in aortic stenosis is typically described as a soft murmur, and it's a harsh murmur. So the quality is harsh. It's like the rubbing of two papers. Now the pitch of the murmur totally varies, but usually it is a low pitch murmur. Harsh means, I told you, it's like rubbing two papers. That means the sound will not be like a whistle. The sound is more of a mechanical sound. It's a very low pitch hustling sound. And intensity, depending on the thrill, it may be grade 3 or 4. Because the pitch is low, technically you will choose the bell. But here comes another paradoxical thing that you should remember. Base of the heart, that is aortic and pulmonary area, are best audible with the diaphragm. This is not related with the pitch, it is related with the anatomy of the blood vessels. They pick up the sound easier. So although based on the pitch, I would have said that you use bell because it's a low pitch murmur, but technically the base of the heart, irrespective of the pitch, is always auscultated with diaphragm. So what does it tell you? It simply tells you that you auscultate mitral stenosis murmur with the bell. All other murmurs can be auscultated with the diaphragm technically. So you use diaphragm for aortic and pulmonary area. That's a standard technique. And this is aorta, so it's the left side of the heart. So will it be heard best in inspiration or expiration? Of course, expiration. And because the murmur originates in the aortic valve, the sound flows with the blood and is conducted towards the carotid artery along the wall of the carotid. So conduction occurs upwards towards the carotid. In this patient, there is no question of pericarditis, so pericardial valve is absent. So is this clear to everyone? Okay. Raghava Lakshmi, you were asking how to differentiate carotid pulse from conducted sound. Look at the question will give you the answer. Pulse is a palpatory finding. You feel that with your fingers. Sound is an auscultatory finding. You hear that with the stethoscope. So of course you will never confuse between the two. One is felt with the thumb and the other is felt with the stethoscope. They are never simultaneously felt. So I hope this is clear. Okay. So we move on to the remaining part of aortic stenosis. If you do a chest X-ray of aortic stenosis in a patient with aortic stenosis, this is the kind of X-ray you will get, very similar to mitral regurgitation. So what is the most prominent finding that you find here? Yes, cardiomegaly. Because other findings may not be present. If it is left ventricular failure, there may be pulmonary edema. Other than that, cardiomegaly is the most important finding. Initially, cardiomegaly may be not very prominent when the hypertrophy is concentric. Later on, when eccentric hypertrophy occurs, cardiomegaly becomes more prominent. Echocardiogram, again, this is only for your interest. So you can see the aortic stenosis causes a narrow jet of blood to flow out, indicated here by red and blue colors. This is a colored Doppler echocardiogram of aortic stenosis. In a normal case, the amount of blood would have been much more. Here it's only a streak of blood. The common questions that you get in the Viva are like this. Why are you saying that this is aortic stenosis? So how will you answer this? Anyone? Why do you say this is aortic stenosis? You have to summarize all findings starting from inspection. Never jump into auscultation. You will say because in this patient, inspection showed apical impulse, palpation showed that the apex is down and out, forceful and well sustained, and auscultation showed there is a soft A2, narrow split, and there is a ejection systolic murmur radiating to the carotid, heard based over the aortic area. So that is how you summarize all the positive findings. Very good. Yes. So these are the features which suggest this is aortic stenosis. Always take your time, never jump into an answer. You think, organize your answer in the Viva, and then say the best answer. Why do you say this is rheumatic aortic stenosis? Same answer. Either the patient has given you a history, or otherwise you say this is the commonest cause unless otherwise proven. Why do you say there is left ventricular hypertrophy? Who wants to answer this? So how do you justify there is left ventricular hypertrophy? Very good. There is a mitral impulse and apex is forceful, well sustained, down and out. Very good. These indicate that there is a left ventricular hypertrophy. So then the question comes, what are the complications? Some complications have already been mentioned. There may be left ventricular failure, right ventricular hypertrophy, right ventricular failure. There can be recurrent syncope and chest pain. These are the common complications. And as in any valvular disease, there is a higher risk of infective endocarditis and another attack of rheumatic fever. So these are the complications. What are the indicators of severity of aortic stenosis? This is one question that is sometimes asked. That is, after examination of the patient with aortic stenosis, how do you know that the disease is severe or less severe? So we have already discussed so many different clinical features. What are the clinical features that indicate severity of the aortic stenosis? Can someone guess? Yes, the split. Wonderful. Presence of the paradoxical split, presence of heart failure, a loud P2, right ventricular failure, very good, engorged neck vein. That means in the flow chart, as you are moving downwards, the disease is becoming more severe. So anything that you collect from the lower part of the flow chart, they are indicators of severity. Wonderful. I'm glad to see that you are developing a good conception in this. So I hope the phobia of valvular heart disease will no longer be there. You have to visualize the valvular heart disease and accordingly make your answer. Very good. These are the indicators of severity of aortic stenosis. Fine. So how does angina occur in aortic stenosis? You know the answer. A, there is less blood flow in aorta, so coronary circulation decreases. B, there is left ventricular hypertrophy, so demand of the heart increases. So the mismatch between demand and supply causes the angina. The P2 in this particular case was normal. If the patient develops pulmonary hypertension, then there will be loud P2. Let us now start with aortic regurgitation. This is a very easy case. Aortic regurgitation simply means aortic valve cannot close. It can be acute and chronic. All acute regurgitations are due to injury or inflammation. Chronic are usually valvular in nature. So acute can be due to trauma, surgery, rheumatic fever, infective endocarditis. Chronic AR, again here the commonest cause is rheumatic heart disease. Syphilis is an important cause that causes aortic regurgitation by fibrosis. Atherosclerosis and an anatomical deformity called bicuspid aortic valve, they can also cause chronic aortic regurgitation. Rarer causes are Marfan syndrome, where the valve is not properly formed due to collagen defect. Autoimmune diseases like rheumatoid arthritis and SLE that damage the valve, including ankylosing spondylitis, and also vasculitis like Takayasu disease. So these are the less common causes. Again, here the most common cause is rheumatic heart disease. Before we proceed with the hemodynamics of aortic regurgitation, there is something that you must remember here. This is not properly told in many of the textbooks, so I think I should explain this. The clinical features of aortic regurgitation vary widely depending on duration of the disease. And why is it so? So actually, if you ask me what are the features of aortic regurgitation, accurately speaking, the features are not same for recent aortic regurgitation and old aortic regurgitation. This complication was not there in rest of the diseases, but it is particularly present in aortic regurgitation. And for this, you have to understand. I'm drawing a few diagrams for you to understand. Suppose this is the ventricular system of the heart. This is the interventricular septum with a left ventricle and a right ventricle. The aorta comes out of the left ventricle. So aortic regurgitation simply means that when during systole blood enters the aorta, that is normal, but during diastole blood from the aorta comes back. That is what it means. Aortic valve cannot close, so during ventricular diastole blood from the aorta is coming back to the left ventricle. If blood comes back from the aorta to the left ventricle, what will happen? During diastole, the peripheral blood pressure will fall, so you will have a low diastolic blood pressure. But during the next systole, the entire blood will go out, causing a high systolic blood pressure. This difference between SBP and DBP we know is called pulse pressure. So typically you get a high pulse pressure. And we all know that this high pulse pressure that is obviously found in aortic regurgitation is responsible for certain peripheral signs. Some of them have been discussed in your junior classes also. So because of this high pulse pressure, you get water hammer pulse, which is also synonymously called collapsing pulse. The blood vessels look like they are dancing. So you get dancing carotid, which is also called Corrigan sign. Your brachial artery will also be dancing. That is called locomotor brachial. There are more interesting signs. For example, you may have a large difference between blood pressure of the hand and blood pressure of the leg. That is sometimes called heel sign. And then there are very interesting signs like bouncing of the uvula, nodding of the head, etc., etc. My point is not to teach these points. What I'm trying to say is, what is the assumption that I have made here? My assumption here is that during systole, all this blood goes out, and during diastole, most of the blood comes back. Also remember, during the diastole, normal blood flow occurs from the atrium to the ventricle. So it is not the only regurgitant blood that is entering. Blood is also entering from the left atrium to the left ventricle, which is the normal flow of the blood. That is why during diastole, there is a volume overload. The normal blood comes. Along with that, the abnormal blood, shown here with a black color, also comes. And together, the next SBP becomes much higher. But consider one thing. If the normal blood has already come, the normal blood will be filling up a large part of this chamber. So if a large part of this chamber is already filled up with, by normal I mean the blood from the left atrium, then where will the blood that is coming back from the aorta fill? There will be very little space for the blood from aorta to come in, because you have to create a space for that. Which means the moment aortic regurgitation starts by damage to the valve, these signs will not appear, because it takes time for the ventricle to dilate and develop the accommodation capacity for the new blood that is coming. Which means in the early stage of aortic regurgitation, the peripheral signs are absent or very mild. As left ventricular dilatation occurs, the volume of the left ventricle increases and its capacity to receive the regurgitant blood increases. This causes a low diastolic blood pressure. And this is the time when the peripheral signs will start to appear. Now this goes on for years, but you all know that hypertrophy leads to failure. So a time will come when the ventricle will not be able to pump. Then also blood will start to accumulate and there will be no space for the backward flow blood. And so the peripheral signs will gradually disappear. So how will you know at which stage of the disease the patient is? At the early stage of the disease, I'll change the color so that you can read properly. At the early stage of the disease, the patient has no peripheral sign and no sign of left ventricular failure. In moderate disease, moderate AR to severe AR, there will be peripheral signs and either less or no sign of left ventricular failure. But in very severe aortic regurgitation, again there will be no peripheral sign because there is no place for the blood to accumulate. But there will be features of left ventricular failure. This is how the clinical features in aortic regurgitation gradually evolve in the chronic aortic regurgitation. Is this clear to everyone? So we are assuming that we are discussing a moderate to severe AR, and that is how we are discussing the case. But remember that not all patients are similar. So there may be variations in the clinical signs. Okay, fine. So with this part done, I think the rest can be easily understood. In the early phase, the blood that starts coming back actually cannot come back. So basically, although there is aortic regurgitation, change in blood pressure is minimum. So it doesn't affect much. Patient remains less symptomatic or asymptomatic. As the heart enlarges in size due to dilation, the symptoms start to appear. So with this in mind, we will start discussing the hemodynamics of aortic regurgitation. As usual, we will start the hemodynamic discussion with the fundamental pathology. That is, aortic valve cannot close during left ventricular diastole. That is the main problem. As aortic valve cannot close during left ventricular diastole, this causes backflow of blood from aorta to left ventricle. This backflow of blood from aorta to left ventricle causes two effects. As a forward effect, there is less blood in aorta during diastole. And as another effect, there is volume overloading of left ventricle. The less blood during diastole can predispose to attacks of syncope, angina, because you remember heart mainly receives blood during diastole. So if during diastole blood is not going to the coronary artery, heart will be deprived of blood supply. And due to volume overloading of the left ventricle, there will be left ventricular dilation or hypertrophy. The left ventricular dilation gives way to left ventricular failure. And the left ventricular failure causes the typical signs and symptoms of left ventricular failure. If this goes on, there will be left atrial congestion. The left atrial congestion will lead to pulmonary venous congestion. The pulmonary venous congestion will lead to raised pulmonary capillary wedge pressure. Which will then lead to pulmonary edema. This pulmonary edema, if untreated, if remains for a long time, will lead to pulmonary arterial hypertension. And if this remains untreated for a long duration, there will be right ventricular hypertrophy. And if this remains for a long duration, there will be right ventricular failure. So this is the hemodynamic and pathophysiology in a patient with aortic regurgitation. The left atrial congestion can of course cause atrial fibrillation as before. So we can calculate the clinical signs and symptoms from here. If the patient develops pulmonary edema, there will be cough with pink frothy sputum. There will also be bilateral basal crepitations. If the patient develops pulmonary arterial hypertension, of course, there will be palpable and loud P2. If there is right ventricular hypertrophy, you know what will happen. There will be lower left parasternal heave And in severe cases, epigastric pulsation, epigastric impulse. If there is right ventricular failure, typical signs of engorged neck vein, pedal edema, hepatosplenomegaly, and ascites might appear. The backflowing blood now causes a number of effects. This is again very interesting to hear. So what are the different kinds of hemodynamic changes that the backflowing blood causes? The backflow of the blood itself causes a murmur. This murmur is the murmur of aortic regurgitation. And this is a typically early diastolic murmur. So it is an early diastolic murmur, and it's a high-pitched murmur. It has a musical quality. So it's an early diastolic musical murmur of aortic regurgitation. As the blood flows back, the flow of the blood can hit on the mitral valve and prevent the mitral valve from opening. This causes compression of the mitral valve and a functional mitral stenosis. So you can also get a murmur of mitral stenosis. I'm explaining this once again. As blood comes back from the aorta, it as a jet, it forces itself on the mitral valve leaflets. So the mitral valve leaflets are compressed from inside and they cannot open easily. This can lead to a functional mitral stenosis. And this leads to a murmur which is called Austin-Flint murmur. The murmur is totally like mitral stenosis. The only difference is because it's not organic, so there is no opening snap. The increased amount of blood that occurs in the left ventricle, when it goes out through the aortic aperture, then it behaves like abnormal amount of blood flowing through a normal orifice, and therefore it causes a functional aortic stenosis. So you can also get a murmur of aortic stenosis. Only there will be no ejection click because it's a functional murmur. So apart from the early diastolic murmur of aortic regurgitation, you can also get a murmur of mitral stenosis and a functional murmur of aortic stenosis. This is not functional MS in aortic stenosis. This is functional MS in aortic regurgitation. So pictorially, if you visualize this, this is the aorta. And this is where the mitral valve leaflets are. And this is the left ventricle. So when blood comes back as a jet, the blood hits the mitral valve leaflets, closing it further. And this leads to a functional mitral stenosis. And the extra blood that has accumulated here, that huge amount of extra blood now tries to go out in the neck systole. It is more blood for a narrow orifice. This causes functional aortic stenosis. I told you murmur is any sound produced by flow of normal amount of blood through an abnormal orifice or abnormal amount of blood through a normal orifice. Here abnormal amount of blood is flowing through a normal orifice. That is causing functional AS. So at least 3 murmurs. There are also possibilities of more murmurs. I'm not getting into those. But at least these 3 murmurs can be heard wonderfully in aortic regurgitation. So is this clear to everyone? Then I'll move on to the clinical findings. Okay. So as I was talking to you about peripheral signs of aortic regurgitation, these are some of the signs and will not bore you by reading them. All of them are due to wide pulse pressure, which causes shaking of different parts of the body or shaking of some artery or some capillary. That includes water hammer pulse or collapsing pulse, wide pulse pressure, interesting signs like Day-Musset sign, Muller sign, Quenk sign, uh, Trop sign, Durosis sign, Hill sign. These are interesting and each of them can be a topic of discussion. Unfortunately, we don't have the time today. So I'll just go through the names and the mechanism behind each of them are very interesting. You just go through this one. I think if you think well, you will easily make out the mechanisms behind this. So when you do a skiagram, what do you see? In the skiagram, you typically get a left ventricular hypertrophy. And in the echocardiogram, you can see abnormal blood flowing back. You can see the amount of blood that is coming down. That is the regurgitant stream of the blood. And when you do examination of the cardiovascular system in this case, you can easily understand that in the inspection, there will be forceful ill-sustained apex that is visible as an impulse. Palpation will confirm the apex, which is down and out. On auscultation, the classical findings will be, because aortic valve doesn't close, there will be soft A2 and normal S1. If there is a functional mitral stenosis, there can also be a loud S1. And finally, when you do the examination of the murmur, you can find 3 different murmurs. So in this case, if you see, the history will be very similar. So I'm not going through this. So we expect no deformity. Scar and venous prominence may be incidental. The only visible pulsation in this case is in the aortic area. Yes, it is in the mitral area because of the enlarged apex. On palpation, the apex beat will be down and out, and it will be forceful and ill-sustained. Ill because the blood is rapidly going out. Thrill you determine with murmur. There may not be any palpable heart sound or impulse other than apex beat. Now coming to auscultation. So what are the possible findings in a patient with aortic regurgitation? Let us see. In a patient with aortic regurgitation, typically S1 may be normal. In S2, there may be soft A2 and normal P2, unless there is pulmonary hypertension. And I always tell you that it is best to avoid discussion on S3, S4. As A2 happens a bit earlier because the ventricle empties very rapidly, there may be a wide split, or it can also appear to be normal. There is no question of opening snap in aortic valve disease. Ejection click is not present. This is present in stenosis, not in regurgitation. Coming to the classical murmur of mitral regurgitation, the site of the murmur best heard over aortic area or just below the aortic area, which is just below the pulmonary area, which is also called the Erb's area or Erb's point. Timing, as you have seen, this is typically an early diastolic murmur. For all examination of base of the heart, we prefer the patient to stoop forward. For all examination of base of the heart, we use diaphragm. All left-sided murmurs are accentuated on expiration. Intensity will be grade 3 or 4, depending on whether you get a thrill. The quality of this murmur is musical. It's typically defined as a high-pitched musical murmur sometimes compared with a dove or a seagull. The pitch is high, so it justifies the use of diaphragm in this case also. And so this is the typical characteristic with which the murmur presents. So it's an early diastolic murmur, high pitched, and it is best heard over the aortic area or in the Erb's area. And the murmur is heard with the diaphragm of the stethoscope, patient sitting up and stooping forward. It is heard best in expiration, and these are pretty much the features. It is not specifically conducted. Some people say it is conducted towards the apex, which is not wrong. That is the reason why it compresses on the mitral valve, but you can also say not conducted if you don't get the conduction. The direction is opposite to carotid, Sneha. Remember, the blood is coming in opposite direction, so it is conducted towards the apex. That is a better designation. And the question of rub does not come, so rub is absent. So I hope this is clear to everyone. So I think this will be a good exercise for all of you. You try to fill up this chart. I'll just give you clues for this. I hope you don't want me to fill this up. Do you want me to fill this up? The comparison between AR, functional AS, Austin-Flint murmur, and MR. Okay, let us do this. Then I'll do it very fast. We'll go one by one. Organic AR means the casual AR that we are reading about. So all the features we have already mentioned. The site is either aortic or Erb's. I think I can use black color, that will make it easier for you to see. The timing is early diastolic. Position of the patient is stooped forward. You always use diaphragm for the base of the heart. Left-sided murmurs are best heard with expiration. Intensity is variable. It can be grade 3 or 4. Pitch is usually high. Quality is musical. Very good. And conduction is usually to the apex or not conducted. Functional aortic stenosis has all features of aortic stenosis, except that there is no ejection click. That indicates the valvular nature. So site is aortic. Timing, you know, it is ejection systolic. Position is stooped. You always use diaphragm. Best heard in expiration. Intensity, now there is one hint I should tell you. Usually functional murmurs are not very loud. There is no rule. There is absolutely no rule like this. It can be loud, but usually they are not very loud. So their grade never usually crosses 3. So you don't get a thrill with a functional murmur. So usually the grade will be 2 to 3 instead of 3 to 4. Pitch of this murmur is low. Quality you already know is harsh. And the conduction occurs towards the carotid. Coming to the Austin-Flint murmur. Remember, Austin-Flint murmur is nothing but a functional mitral stenosis. So you'll get all these features. So in Austin-Flint murmur, the site will be mitral or apex. Timing will be diastolic or mid-diastolic. Now there is one trick that you should remember. This is often not properly written in many books. What is the cause of this Austin-Flint murmur? Who is compressing the mitral valve? The regurgitant blood. That is it. Now look at the duration of the murmur of organic AR. When is this blood most rapidly flowing, causing the sound? Mid diastole or early diastole? Look at the organic AR, I am saying. In organic AR, what is the timing? It is early diastole. It is the same blood that is compressing the mitral valve. So it is probably physiologically more correct to say that the Austin Flint murmur is early to mid diastolic instead of mid to late diastolic. That is the difference between Austin Flint murmur and the actual organic MS murmur. Because if the blood is flowing in the early diastole, how can the compression occur in the late diastole? Middle part I understand that can overlap. So that is why this murmur is not technically an mid to late diastolic murmur. It should be called an early to mid diastolic murmur. That is the difference with the classical mitral stenosis murmur. The position of the patient will be either stooped or left lateral. It is heard best with the bell. Of course, expiration for all left-sided murmur. Functional murmurs are usually 2 to 3 in grade. The pitch, is low. The quality is rumbling. And there is no conduction. So rest of the things are like mitral stenosis. Sometimes the left ventricle can dilate so much that the mitral valve leaflets are taken away from each other due to increase in diameter. In those cases, we say there is a ring dilation. This produces mitral regurgitation. That is a kind of an organic murmur, not exactly functional. So you get all characteristics of mitral regurgitation. So the site of the murmur will be apex. The timing of the murmur will be pansystolic. Position of the patient will be stooped or left lateral. You should use the diaphragm. Heart based in expiration because it is left-sided. This is a kind of an organic murmur, so it can range between 3 to 4. The pitch, as you know, is high. The quality is blowing murmur, and conduction occurs to the apex or back. I'm sorry, axilla or back. So I think now it will be easy for you to compare the murmurs. This itself, you can understand, can be a very interesting theoretical question. The auscultatory findings in aortic regurgitation. So you start with the heart sound, comment on the other findings like S1, S2, split, etc., and then compare the 4 murmurs. So is this clear to everyone? Okay. There is no easy way to remember the pitch, honestly speaking. In general, although this is again not a rule, in general you see stenosis murmur tends to be more low pitched and regurgitation murmurs tend to be harsh. But this is only in selected cases, not always. So now maybe this is a time when we can actually check whether our understanding of the aortic valve pathology was adequate. Let us quickly solve the MCQs and end the session. So angina can occur in, what will be the right answer? All of the above. Very good. Forceful and ill-sustained apex is seen in. Very good. It's aortic regurgitation. In mitral stenosis, there is tapping apex. In aortic stenosis, there is forceful and well-sustained apex. In aortic regurgitation, there is forceful and ill-sustained apex. Collapsing pulse is seen in. Very good. Collapsing pulse is same as water hammer pulse. Murmur of aortic stenosis is. Yes, it is ejection systolic murmur. Paradoxical splitting of second heart sound can be seen in. Very good. It's classically seen in severe aortic stenosis. So answer is C, aortic stenosis. Austin Flint murmur is not. Yes, very good. This is a tricky question because functional MS due to compression is not MS. It is actually found in AR. So the answer is C. It is not found in mitral stenosis. So these were the questions. I hope you enjoyed the session. It was not that boring. So if you have any questions, you can ask me. And Pranava, Vishnu, you can take over.
Yes. If anyone has any questions, you can please put it in the chat box. So I think we have questions.
Okay, so you are asking about pulmonary venous hypertension. There is no such term. I only use the term to confuse all of you. Venous hypertension essentially is venous congestion. Your question, Deblina, is if aortic regurgitation impulse is seen both in mitral and aortic area. See, there is nothing called aortic regurgitation impulse, but in that case, you see left ventricular hypertrophy occurs, so you will get a mitral impulse. Now, aortic impulse occurs in aortic aneurysm. That is not seen in aortic regurgitation. So there will be no impulse in aortic area. You can also think of it in an easier way. In aortic regurgitation, the abnormal blood goes down, not up. Aortic area is above the aorta, not below the aorta. So there will be no impulse in the aortic area. So I think the questions are mostly answered. So Pranava, you can conclude the session.
Yes, sir. Thank you so much, sir, for the two-day workshop. It was brilliant. I mean, thank you so much for your time and effort, and we are truly grateful. And I hope these concepts are clear for everyone now. And we have also recorded the sessions, and we'll be posting it on our YouTube channel so that those who have missed can also cover it up. Or if anyone wants like a revision, they can also see it later.